Hello, welcome. Thank you for joining this. I'm Matt Bobman, and I'm excited to be talking to Dustin Grooms and Meredith Chaput today. And they are the authors of a really great blog that we just posted called Reengaging the Brain, Restoration or Compensation of Motor Control. Dr. Grooms is on faculty at Ohio University in the athletic training program. Meredith is a PhD student at Ohio University studying translational biomedical sciences. This blog, I think, has been really well received. I didn't see any Twitter blow-ups, which I was a little disappointed about, but it's probably for the best. I think it was really well received at least on Twitter. Before we get into the questions, I'd like to have Meredith and Dustin take a second each and just tell us what they're researching and what they're studying. So thanks for joining me, guys, and just tell everyone what you're learning right now.
Sure. So our lab focuses on using neuroimaging to measure the brain, and then a 3D motion capture lab to measure human movement. And so what we primarily study is this interaction of how the nervous system changes after injury, and then how that influences people's motor performance. And then a big part of our lab over the last few years is how do we try to fix some of these deficits we see in how the brain generates movement after injury with some novel interventions, and addressing cognition is one piece of many that the blog was about. And so I'm happy to expand on that and a lot of the other topics we have in the lab. And Meredith is now an integral part.
I am a first-year PhD student under Dr. Grooms, and so specifically I'm interested in a lot of the cognitive contributions that we talked about in the blog, and I'm interested in how athletes make decisions, and then how can we integrate kind of cognitive neuroscience, skill acquisition, and motor learning together to improve our rehabilitation after ACL injury.
Oh, that's really great stuff. Okay, so we got some good questions on Slido, and I've been through them, and I think I'll just head through them and give you guys a chance to answer. Okay, so the first question made me laugh. I really like this one. It's some of this seems obvious. Why is it not standard?
Go ahead, Meredith.
That's a really good question, because it does kind of seem obvious. And I think from a new grad perspective, we learn about a lot of this in our neurologic physical therapy courses, but then it just never really translates to the orthopedic or sports side of things. And so I think it's an area that we can really grow upon in both PT education as well as transitioning into our rehabilitation interventions clinically.
So the only thing I would add is I think a lot of it is limited by our techniques and science to measure things. So we also think about like the SAID principle, or specific adaptations imposed demands, and we think of it in terms of mostly muscle performance, as most people tend to think of it as, but it also applies to motor skills. And it's only in the last 10, 20 years where we can actually measure some of these neural changes, and they have the exact same principles. So you don't want your white matter to degrade in a specific track. You have neural activity on that track. And we allow some of that to atrophy or degrade with injury. And I think some of that's just been limited by our inability to measure those. But I think once you have this more fundamental understanding, a lot of this starts to become a little bit obvious, that the ability to generate exceptional quadriceps contraction laying on the table probably doesn't translate to having that activation at the precise time and moment when you need it in a very challenging sport context.
Yeah,
I don't put the blame on clinicians.
For the record, I don't think it's that obvious. So, one of the major problems after an ACL injury, and especially after surgery, is atrophy. Just recently, I saw on Twitter an article by Lindsay Lepley and her crew kind of broke down the different mechanisms of muscle atrophy. And what caught my eye is one of the articles that Dustin here, along with Ali Gokler and a few other people from that group, co-authored, and that was actually cited as a rationale for motor control to limit muscle atrophy or combat it rather. And I'm just wondering, does that have, is it proven? I mean, that was, I think that was a review article you guys wrote.
Yeah, so since I was co-author, I'll go first, then Meredith on this one. Then you have to take the next one. The question is absolutely right. So that article was not a randomized controlled trial on does a particular motor learning intervention improve muscle or decrease muscle atrophy probability in people with like ACL injury. So that, to my knowledge, probably hasn't been done to that extent. And there's actually not a lot of really high quality randomized controlled trials in our field and rehabilitation in general. So really, you could almost apply that question to almost anything we do, sadly. Now, with that said, that review article, we did highlight a few motor learning principles that seem to target some of the same neural mechanisms that we think drive muscle weakness. And so you can use implicit learning to try to improve efficiency of frontal parietal connectivity. And what that means is that helps with perception action coupling. Basically, that's a lot of words to say using knowledge of where you are in space to help you get where you want to go in space. And there's some really interesting studies that used TMS or transcranial mag stim to look at excitability of the corticospinal system and shows that implicit learning may improve this. And we know that's disrupted after ACL injuries. That's just one example of several. So I think the reason why that review article was cited is we don't have a lot of high quality RCTs to go on, but we see overlapping mechanisms of deficit in the ACL reconstructed group that contributes to muscle weakness and an ability to target them with some of the motor learning strategies. You want to add anything, Meredith?
I have nothing. Nothing to add.
Okay. Well, that I guess that sort of answers my next question, which is, have there been efficacy studies? Have there been like pre and post, I don't know, fMRI studies where they looked at connectivity or what you're recruiting before an intervention, train a certain way, and then do it after?
So that is a little bit of a different question. It's a little less specific to ACL and muscle mechanics specifically. And there is some compelling, at least more compelling evidence that the mechanistic pathway is there. So the TMS study was just one I mentioned. I published a paper with Jed Diekvis and Greg Meyer from Cincinnati Children's where we did an implicit-based neuromuscular training program where they got augmented reality biofeedback that trained them to learn to move with low injury risk, like high knee flexion during a squat and no knee valgus, symmetric loading patterns during landing, that sort of thing. And it was implicit because we just had a rectangle shape that would be displayed, and they were told to make the perfect rectangle, and that shape would deform based on those key injury risk variables, but the participants had no idea that the shape was deforming on them. And so after 6 weeks of this implicit training, we had pre-post brain imaging and we had pre-post biomechanics on them. And they obviously improved their biomechanics from training, but they also had a much more efficient motor cortex activation pattern in that it didn't require as much M1 or motor cortex activity to generate knee movement. And a lot of that was augmented with increased sensory activity or sort of auxiliary or secondary areas, which coincide with what we know how your brain learns to move implicitly. Because if you learn explicitly, we tend to see a lot of frontal cortex activity, a lot of thinking regions, a lot of cognitive region activity, which is how we normally train. So that's what we see in the control group for neuromuscular training. But if you engage in this augmented implicit training, we see this supportive neuroplastic effect of sensory increase, no frontal increase, and then that M1 efficient response. So that's just an example from our field. We published that in Journal of Sport Rehabilitation. But in other fields that have much broader implications, I was looking at I think this question reminded me, there was a really, really cool study in fall prevention. So if you think of a fall as similar to an ACL injury, where it's basically a motor error. So a lot of falls are non-contact in nature, sort of similar to ACL injury, where someone is walking and they have a misstep. It's not that, the bus hits them and they fall over, or someone bumps them. It's a lot of time in your own home. and you just misjudge where you think the handrail is, or you misjudge where that step is. And so you make essentially an error similar to non-contact injury. And one of the most effective interventions for that is dancing, because it requires a lot of stepping, and there's a lot of unique motor learning principles to dance. And actually, after you get to the first initial stage, you tend to get a lot of implicit cues with dancing. So they don't tell you like exactly how to move, but more like what form to take. So it's some interesting data there. But in that study, it increased or it decreased white matter hyperintensity and improved a lot of our diffusion white matter metrics, indicating a more efficient white matter pathway where all of your neural activity travels on. And they didn't see that with standard interventions. And they compared some of these to standard physical therapy, which is standard like balance and strengthening. They don't get those same neural adaptations. And so I think there's some reasonably compelling evidence in our field and others that have applied to this idea to these similar principles in other populations, that it can improve your ability to prevent these errors which lead to injury, and it has a concurrent neuroplastic effect with it.
Yeah, it's I'll say that I did, as I was making the social media rounds trying to get the word out, someone on Facebook mentioned, after reading the blog, they said something like, I've been working with stroke patients for 10 years and just transitioned over to ortho and sports, and this makes a lot of sense. And I think that's interesting.
That's great.
Yeah. So Sylvia here on our live chat here has a good question. What's the dosing you would recommend to get the benefits you're hoping to get with this kind of training? Conceptually, it makes sense, but I'm sure an effect from 1 to 2 times a week in therapy doesn't seem like it would be enough to create the desired neuro changes.
That's good. You have to go first this time, Meredith.
I'm going to go for that. Okay. That's actually a really good question. And I guess the simplest way that I kind of conceptualize it
Did we lose her, Matt, or is it on my end?
Can you hear me?
Yeah, I can hear you loud and clear.
Okay, I can't hear Meredith, actually.
So, Matt, you can hear me though?
Yes.
Okay. So the way that I guess I would conceptualize this is, to my knowledge, there's not a specific dosage like you would do exercise or a strength and conditioning training specific for cognitive interventions. But if you think about it, you could use like an RPE scale, and that has been done before, where you allow the individual to gauge the level of complexity that the cognitive challenge is accruing over the top of the physical skill that you're performing as well. We actually just collaborated with a couple of clinicians from Ohio State University to try to lay out a framework for this exact answer as far as an injury prevention program would go. How do we kind of use a motor learning framework to then assess an individual's cognitive ability overlaid with their physical ability as well? And so you're right. I think that 1 to 2 times a week in therapy probably isn't enough. Just like if you do your quadriceps strengthening 3 sets of 10, 1 to 2 times a week, you're probably not going to recover your quadriceps strength back. But a specific dosage, I don't know that we have that set in stone. Anything to add, Dr. Grooms?
The only thing I would add is that there is, in some of our data that we were able to collect before COVID, we had this ongoing longitudinal study to track people across time. So most of our prior data on this point was cross-sectional in nature, where we only had people measured at one time point after injury. So we're tracking them over time. And we've been looking at some of their strength data and sort of how that trajectory of recovery and then their neural recovery. And I think there's a compelling rationale that if you could avoid a lot of some of these neural deficits setting in, that you might not need that much of a dose later. And so a lot of our studies that show this high dual task cost in people after musculoskeletal injury, and what I mean by that is when you challenge them with a cognitive task or just a secondary task, really, when they're trying to perform a motor task, that could range from just generating a quad contraction to squatting to landing, and you make them track something in the world or respond to verbal cues or what have you, that those people have these higher dual task costs 6 months, years later, and then we're trying to like play catch up, and then you need a high dose. And so there's really interesting motor learning literature where if like many people have sort of maybe heard the take home point for a lot of it, like correcting a bad movement pattern is much harder than like just instilling a good one, right? Because once you have this idea where you have some sort of motor strategy set in, to modify it can be much more difficult. And so what I would advise, if you could start it as soon as possible, even at a very basic level, that you might avoid that with them relying on explicit cues or cognition for movement, and you might not need that much of a dose. I don't have a clinical trial to say that, but I don't think adding it to your current strength regimen early on would harm them, because you're still going to get the same goals you always have, and that there's minimal risk to having them think while moving or think while generating a contraction, even on the table.
Do the popular prevention programs out there incorporate these ideas, fundamentals?
I think you just were talking about the paper you wrote with Joey and Caroline at Ohio State, Meredith, right? You want to elaborate more?
Yeah, well, we put together a framework that based 3 motor learning stages, and then how we might overlay cognitive interventions to a traditional program that maybe consisted of double leg jumps, progressing to single leg landings, and then change of direction. And so within each of the 3 stages of learning, you would progress the cognitive load. So within the first stage, you might do something that's like a simple working memory task. So as somebody is performing an exercise, performing squat jumps or whatever that might be, you're having them do like a serial 7 subtraction task, just to kind of keep their mind away from their movement that they're performing. And then they would progress to something that would be like congruent, or like having to react to a stimulus that's given by an instructor, so that they're then having to use their vision to track an object or instructor's fingers outside of them, so that they have to make a decision similar to what they would do in sport. And then maybe the last stage would be like response inhibition, where they have a movement goal in place, but now they have to inhibit that response and pick a different selection based off of a cue that's given through an instructor. To my knowledge, traditional injury prevention programs don't necessarily have that exact structure to them. I do know that Sports Metrics has a neurocognitive component to it, but I'm not very familiar with that program, honestly, in general. I don't know if you are better, Dr. Grooms.
I don't know that program off the top of my head either. There was a cool paper. I'll send it to Matt after this. Sorry, I didn't include it earlier. It's called Sensory Motor Training for Injury Prevention in Collegiate Soccer Players, an Experimental Study, and it's in physical therapy and sport by Rineker. And it was this really neat study where they included a lot of these kind of ideas, and they kind of loaded them all in, and they tried a lot of them. They had a lot of positive effects. They didn't track injuries going on in the season, but it was an example of someone applying a lot of these clinically to try to prevent injuries. And they had a lot of fundamental improvements in a lot of the neurocognitive and motor performance variables. So I'd encourage that paper if you wanted to see how someone's tried to implement a lot of this from a prevention standpoint.
Meredith, I don't know if you can see, but Jonathan Sandberg has a question. Can you give an example of the last stage you just described?
Sure. So for like response inhibition, let's say, I guess you could progress it in 2 ways. Like if you had somebody perform a skill, let's say like a math problem, you could do like a multiple step decision making. So where somebody has to perform like a jump, and then they have to solve this math problem. If the answer is even, they perform this task next. If the answer is odd, they perform a different task next. There's technologies kind of like FitLights that you can use, or you can make flashcards in the clinic that are different colors, and you can give the flashcards meaning to them. So where the individual has to like anticipate on this color, you're going to perform this exercise. I don't know if that answers your question, Jonathan.
Perfect, he says. Okay. Well, I have one more question from the Slido before we move on to kind of another phase. And that, I think you kind of already mentioned it, but the question was, are there any trials planned to look for changes in outcomes like return to sport or quality of life or things like that?
So the paper I was talking about earlier, it was brain behavior changes from normal training and journal sport rehab. That was at a preliminary cohort where we did do an intervention incorporating several of these principles. This was the augmented reality biofeedback training. So that's ongoing. That was shut down with COVID with Cincinnati Children's Hospital and Dr. Meyer and Dr. Deekvis. We hope to pick that up, and then we'll have some much more intervention-based data to share. So that's very specific to our field. So a lot of these principles depend on like the fall prevention training or gait retraining or stroke retraining, a lot of these other disciplines, because a lot of our data is we're just trying to match pathology-induced deficits with what we know the intervention can do. So I think we're at this stage in research for now where we're starting to actually test them in our athletes to sort of bridge that gap. So hopefully soon.
Great. So I think we can kind of move on to the next phase, which is a little bit more practice oriented. And you did mention this a little bit, so I have a couple follow-ups. Is it possible to set a client back by starting with like an internal focused exercise and just working solely on that, maybe post-op day one till, I don't know, 6 weeks or something. And then you maybe make a transition to external focused exercises. I mean, can we make them bad learners?
That's an interesting question. So from what we were talking about before with the compensation idea, I try to get them out of internal focus as fast as possible. I'm interested, Meredith is coming from the clinic a little sooner than it's been a few more years for me, but the ACLR patients we get through our athletics and athletic training, and from time to time, I always try to push them through, but sometimes you're just going to get people who are going to struggle to coordinate their body, and it's hard to progress them. But I try to just get away from allowing them to use vision to program motion, use cognition as fast as I can. I use any means possible. I think the external focus is good because you can give them a target and kind of trick their body into doing whatever they want. Whatever you want with using the world as cues instead of using internal focus cues where they're paying attention to their body. So I think really once you get this sort of idea, it's really just limited by your creativity. And so I don't think I would use internal focus as a crutch as much as I would use as minimally as possible. What do you think, Meredith?
I guess my first question that I ask myself and my patient is, like what their sport is, because to me, if they're like a dancer, that might be something that I use a little bit longer, just because it's going to correlate to what they have to do in their practice of their sport more efficiently than adopting like an external focus as soon as possible. That would be like one of the only exceptions for me clinically. Otherwise, I say this all the time, what I saw was that the less I spoke, the better my patients performed. And so the initial learning or initially understanding what the goal of what I want them to do, whether it's a quad set or a straight leg raise without lag, just explaining to them the concept of it and then allowing them to think about it for the first few times that they perform that exercise, but then getting away from it as fast as possible, people actually performed better because they weren't perseverating on the fact that they had a couple degree extension lag. Otherwise, you might get somebody who's really competitive who then gets down on themselves because they're not progressing exactly at where they think they should be. So I think adopting an external focus of attention and just using a cognitive strategy too really helps the psychosocial aspect of recovery early on as well.
One thing I'll add, one of the links I sent you, Matt, I know it was right before this, was the last also Dr. Cortez at Georgia Mason. He's done a few cool studies with this, where he does exactly what Meredith pointed out, where you give people mostly knowledge of results, like that was a good movement, bad movement. You try to speak as little as you can. And that's actually induces implicit learning because they have to program or figure out how they're going to move without using you as a crutch to get them through it, because you're not going to be there when they have to move on the field. And so that neural activation pattern, when someone moves without explicit feedback and they're told good, bad, is extremely different. Like they fundamentally program the movement differently, even if it looks exactly the same. And so that can be extremely powerful. So that's something we didn't go on in the blog too much about, alternative ways to induce implicit learning or implicit-based movement. We mostly use the dual task theory of cognition to force an implicit strategy, but just shutting up and letting your patient like figure it out a little bit it is also powerful. But this is also where you have to be a clinician. So everything we're saying here, it's not a checklist or like you just do this and you'll magically make all your patients be better. This is why you're not just a technician, you get told what to do. That's why you have to use your brain. This is why being a clinician is hard, because we have incomplete data and you have to make a treatment decision based on incomplete data because science hasn't answered all these questions for us yet. And so you have to judge it, progress your patient, and you'll sometimes go too fast and you'll have to give them more feedback. And that's okay. Just like when you're advancing them in strength training, sometimes you might put a little too much and you have to pull back on them. So that's the only thing I'd add.
The article you're just talking about, is it by Elmar Call?
Implicit's in the title. It was a jump landing study.
Okay. Oh, a jump landing study.
Yeah, sorry. I know the PubMed links aren't very helpful because it's just a bunch of numbers. But.
Yeah. Let me see. Let me just run through them real quick because if I can.
Let's see if we have any other questions.
So while I look for that, let me, I have a couple follow-ups to that. I think this is a really great question I saw on Slido. Are there complications in starting multi-years post ACLR? Like, can it be regained if you're just starting this years after the surgery?
What do you think?
I was going to wait for you to talk about some evidence.
Your turn. You have to go.
So what I say, I think there was another question that I had seen on Slido about specificity of your neurocognitive training as well. So you're going to train what you train, right? So if I train throwing a dart at like 1 yard away, I'm going to get really good at that. But that doesn't mean when I go back to the standard dart distance to play a game that I'm going to become good at it. So I probably can't just take an impact test or do a computer visual motor cognitive test and then that translate to my visual motor ability in my sport performance. So that being said, I think that there's a component to that, yes, with work and recovery, we can improve what is happening. Your brain is plastic, just like your muscles lose and gain strength. Your brain operates in a similar fashion. But what do you have to add, Dr. Grooms?
So it's like we talked about before, it's going to be a little bit harder. There's no reason why you can't try to change it, though. I mean, I would give it a shot just like anything else. Like once someone has been detrained for a long time, you're trying to recover muscle strength, that's also extremely hard because then you get fatty infiltration and you see a similar phenomenon in the nervous system actually, where you'll get white matter hyperintensities, you'll see less parallel diffusion in the white matter, you'll start to lose integrity. So a lot of the things we associate with detraining of muscle tissue, which is very well studied and most people have a better grasp, we see similar changes in the nervous system. But there was a cool, really interesting study that did gait retraining in elderly. So we normally used to think that your nervous system gets less plastic over time. And so I'm going to borrow from another field because I don't have a phenomenal answer for you in people years after ACL injury. But this what I'm going to talk about in these couple series of studies out of Pittsburgh, I think will really show that it's definitely possible. So they had people who have slow gait speed and you're older. And we know you have a less probability of neuroplastic change as you age. Just like any other physiologic system, its plasticity decreases or its ability to adapt. And so one group got standard gait training, like strength exercises, balance, gait training. The other group got precise timing and motor coordination training, which included a lot of they used split belt treadmill. They would do a lot of metronome timing. They did a lot of coordination drills, and they actually incorporated some of these implicit motor learning ideas and some cognitive challenge to their training. So the standard group, they both got to walk faster as you'd expect because their muscle system got better. They had minimal change in their white matter hyperintensities in the corpus callosum. So corpus callosum connects the left and right hemisphere, very important for walking. So when that starts to degrade, your ability to have your left move, then your right move, and back and forth starts to go down as well. And so as you can imagine, it's the communication pathway in the corpus callosum starts to break down with aging. You lose some gait speed, so that makes sense. And the standard group, they saw still some degrade over the 6-month time period of the intervention in the corpus callosum. The timing and coordination group, some people actually reversed the degrade, which is amazing because it's very hard to change white matter track. This is like structural brain morphologic change from a conservative coordination, motor control based intervention. And so if that doesn't speak to the power of some of these ideas, then I'm not sure if I'll be able to convince you of anything, because you basically took the people who had minimal capability and you were able to reverse some of that. It's extremely difficult to manipulate. So it wasn't just the neural activity of M1 change, which is interesting. This is hardcore, and then that delays their progression. So not only do they reverse it also delays them getting worse. And they don't have follow-up data, but it's compelling so far because they just finished their first arm in that clinical trial. So I would say go for it. To the long story short, for the ACL, I'd give it a shot. If it works in that population, then I think it could definitely work for us. Do you want me to read the Katie Reese question?
Sure. Yeah, sure, go for it.
Is it more common to see a patient perform better with dual tasking cognitive tasks than when they plan the movement or consciously think about it? Do they tend to hesitate more with the planned movement rather than naturally moving, similar to what Meredith just touched on, giving less verbal? This is a super cool question. I like this question a lot. And so when they go to move and you give them a cognitive task, this phenomenon is sort of interesting. And there's some data in elite performers that there's some interesting even neuroimaging data where they look at how elite performers can isolate on select salient variables. So they looked at elite quarterbacks and elite basketball players, and I think it was skiers. And they would have them lay in the scanner. They would try to predict what's going to happen, and they would do eye tracking. And what they find is that when you try to cognitively load people, they would have numbers flash in a corner, and you'd have to use your peripheral vision to track the numbers like a dual task, but then see what's going on in the field and read the field and attend to the variables. So as movement performance goes up, you might find that the cognitive challenge does not impact people's motor performance very much because they are that motor pattern so implicitly grained in that their autonomous stage, you won't see much of a dual task cost. And then when you make them focus on it, you'll see the reverse. You'll see the performance break down. It's because you have two separate neural activation strategies to move. They've gotten really good at the implicit one, and then you made them use something that they're not very good at using. Which is you made them attend to the movement, which is not what they've been trained to do or what they're trying to do. And so that's a really cool question, and it sort of integrates a lot of literature to answer it, because I don't think there's one study that's really answered that one exactly, but I really like that. It's a really, really cool thought. Did you want to add, Meredith?
Nope, you nailed it. I have this conversation with one of my friends from PT school, actually, quite a bit, about how she even sees it in the clinic still, where it's okay, I made them do this thing. I thought it was going to make their performance worse. And visually, whatever their physical performance was actually improved. But I would say the caveat to that is can you measure also their cognitive performance at the same time? Whether it's errors on whatever working memory task that you're providing them, that kind of thing, to make sure that they're actually attending to the cognitive task that you're putting forth in your intervention.
That leads perfectly into my next question, which is there a way to standardize the cognitive loads? Like, how do we make them repeatable? How do we make them, how do we make sure that we're applying them same and then grading them appropriately? And how can we transmit that from day to day or even patient to patient and get good repeatable results?
It's good. Your turn, Meredith.
I think one of the easiest things to do is have like a PowerPoint of different cognitive tasks, whether it's like a Stroop task, working memory tasks, that kind of thing, because then you're consistently using similar materials as you're displaying the dual task, but also in the same sense that you document your 3 sets of whatever exercise or circuit that you do, you should be documenting what cognitive challenge you're incorporating into what interventions in therapy.
So one thing I would add is you can also, I find it's really easy to conceptualize. You're customizing the load to the person. So I conceptualize a lot of my therapy the same way I do strength training. And so if you have 100-pound, if someone can lift 100 pounds with their quad, or take simple math for me, that's why he's 100 pounds. Not many people might be able to like knee extend 100 pounds. Maybe it's a lot, but you're not going to load them with 10 pounds. You want to expect an adaptation, right? You're going to use 10% of load. It's going to be very difficult. You can do the same thing with a lot of the neurocognitive loading. So like the items Meredith was using, you could calibrate the speed they're delivered or the duration they're delivered or the complexity of them. And so easy ways to do it. One is you can use the Welch. It's WESLCH. I think it's very simple. It's just a digit span test. You can do the test like 2 minutes. You get an idea for how many digits people can recall in a single session. And this is where I think the average human is like 6 or 7 at a time. And that's like your max. So you think, okay, and there's like a standard deviation of like 2 digits for humans. So you're like, okay, if this dude can only remember 5 digits, that's his max cognitive load. So I don't want to train him probably at his max because he'll have failures, right? So I probably don't want to have too many cognitive processes or force him to remember anything more than like 5 steps. So maybe like 3 steps is good for them. And what I mean by steps is, I mean like how many cognitive challenges I might give in an exercise, for instance, or like how many numbers they have to add in a row. Oh, thanks. That's perfect. Thank you, Matt. Or the complexity of like addition or serial subtraction you might use, or how many things I got to track in the environment. You can use this to sort of calibrate, get an idea where your patient is. The other one is there's a puck drop test, which gives you an idea of people's reaction time. And so you may have seen it for concussion. Basically, it's a stick with a puck on the end. So I really love clinical tools because one thing I hate is and I know I've talked about this with Meredith, and that's one reason why Meredith is really, I think, passionate about a lot of this. Our lab really tries to translate a lot of this stuff. So we'll use really fancy technology, but then we try to make it clinical if we can, because I was very frustrated as a clinician not being able to implement a lot of things. So the puck drop test, stick with a puck, drop it, and you have grip it. So it's like holding it and the stick, and then you let go, and then they have to try to grip it. And then you get the distance they traveled, and then quick formula, you get the reaction time. And then you can also calibrate based on reaction time, like the PowerPoint Meredith was talking about, that might just cycle through numbers, and they have to do an exercise based on the number or the color. You might calibrate that timing based on that person's reaction time. So if someone is really quick, then you might have it go faster. And it also depends on the exercise you're prescribing. And someone who is not, you may have it go slower, for instance. So there are little quick clinical tests you can do to gauge the cognitive capabilities of your athlete at the time, and then you can try to tailor your interventions to them.
Someone asked whether or not training apps like Lumosity could be useful, or tests that sort of test your working memory. To me, like a puck drop test is how much to do with the knee. Are there some uses for like brain training type deals?
Let's see, I guess I have to go first this time. So. So the brain training, that's an interesting one. So that would be like if you isolated improvement in cognition, would that improve like knee neuromuscular performance or recovery? That's an interesting one. Now, do you have some of the papers we cite in the blog do show that isolated deficits in neurocognition, especially visual motor reaction time and visual memory, may influence your injury risk. So there's definitely a connection there. So in theory, you would think if I could improve those variables, if they're predictive of injury, then that should decrease my chance of injury. But that study, I don't think has been done. So I'm not going to say that's definitely the thing to do. It would make sense, though, that if you could improve those variables, that people's anticipatory timing could improve. There's been a few studies, most of these are in concussion, where they look at collision avoidance, and people's visual motor reaction time decreases impact severity, where they would get less G-force over the course of a season compared to matched athletes, comparison to the same sports, same exposures. And then also, if people had about a quarter of a second with eye tracking before they were hit. So they did these cool secondary views of like games and stuff where people got hit and they got a diagnosed concussion later, or they had concussion data or they had head accelerometer data in the helmets. And the people who were able to see the blow coming and stiffen and be prepared, about a quarter of a second, they had less impacts. So it would make sense that if you could improve that speed, that you could anticipate for things and you may be able to avoid injury, avoid collisions, avoid impacts. But I'm not aware of an intervention that's gone that far. And typically in training, we try to, and for rehabilitation, we try to try everything to what we're training. So I wouldn't necessarily advocate doing isolated neurocognitive training in someone with ACL if you don't have the time. Because you only have so much time with your therapy, and a lot of you are thinking like, holy crap, I don't have more time with my patient. I already don't have enough time with them. I can't do anything more. I already have too much to do. I can't do anything. So what we try to do is we try to layer them on top of each other. So if you're already doing a lot of these exercises to recover strength, range of motion, gain flexibility, whatever it is, try to just do this at the same time. I don't want to make them do more. So I would probably start there before I would jump to isolated training. And the puck drop example is just to get an idea of cognition in general. You're right, it's not tied to their knee specific performance. You could maybe do like a tibia drop, like where you hold them and see like their quads react in time. That would be a pretty cool clinical test of like, something. I don't know. Meredith will work on that tomorrow probably. Do you have anything to add?
No, I thought that was really good. I think a lot of the literature that I've read pertaining to cognitive intervention, especially like neuroimaging, they all have upper extremity components to it. And so we don't have a lot of data on lower extremity reaction time. And so we're assuming that your upper extremity reaction is correlating to your lower extremity reaction and responses. So that's why I think specificity in what you train is so important, specifically.
So Jonathan's got a great question I like to answer. So he asks, do you worry or is it a concern that by adding cognitive cues during strengthening moves like a barbell squat will decrease the goal of the strengthening exercise? How do you balance striving for cognitive and strengthening advances? So this is really good points. Something that I when I worked with strength coaches in the past, and what I recommend is you throw a lot of this away when you're doing really heavy resistance training, because heavy resistance training alone is a high cognitive load, because you are at high risk for injury, because you're really putting, especially when you're approaching like 80% higher max. I don't think I would mess around a lot with this at those moments, because you're training at a pretty aggressive level in and of itself, and they need their focused attention on the movement. What a lot of these things would apply to, so say it's a healthy athlete, you're in a strength and conditioning room, maybe that's your example. What I hate to see is, I feel like it's just a waste. So you have even a high school, well-trained high school athlete, collegiate athlete, they've probably squatted thousands of times for their exercises, take most sports, right? They're in the weight room, they warm up, and they're staring at themselves in the mirror as they warm up, doing a movement they've done over and over and over and over. And I've seen this more and more, I think as this literature gets out, a lot of strength coaches they have curtains over the mirrors. So during your warm-up and prep exercises, and maybe as you're scaling up to really heavy resistance, they don't allow you to look at yourself. So then you have to program it without those external cues, without that crutch. And they may add some cognitive challenges. So I've seen some soccer teams where they'll add they'll like try to cycle the exercises, or they'll add some sort of reactive components. Like they'll have monitors or even fit lights or A-champs or other technologies that will indicate like if they're going to lunge or do a squat, or like when to do the movement. Even that simple, if you just add a reactive component to engage the movement, you can have a lot of benefits there. So they can just be staring at you instead of just doing 3 sets of 10 squats, move at your own pace, they stare at you and you like give like just a go signal. That's simple. No cognitive load, just a reactive load. You're not making them like go on the 2 and you're flashing numbers. So that simple alone can give you a lot of these benefits. But my point is that I don't do those when I'm at 80% or higher of the max, because that is alone is a very high load. So I just wanted to really point that out. Do you have anything to add to that, Meredith? So you got to use your head with a lot of stuff. You don't go crazy.
Yeah, no, I think that's a good point. It goes down to what's your goal for the session, right? If I'm training like max strength, I'm probably not going to layer a cognitive load on top of that, because that doesn't necessarily translate to sport either, right? So I think Dr. Groom's explanation was perfect.
What's this next? Besides mechanics breaking down during functional activity or rating perceived exertion, and any other criteria that you use to determine whether the cognitive load is adequate or too difficult? So for Trevor's question, do you want to take this one, Meredith, first?
So sure. So there's been a couple studies looking at like the LESS test I know I'm most familiar with. And so that's just grading your depth drop ability. And so you already have like this scale. And something that you can do is you can say, okay, this is what they are at baseline, what their landing mechanics look like. There's even like, you could use the tuck jump assessment. There's a single leg landing scoring tool. There's quite a few options out there. But then you can apply a standard cognitive load to that and then reassess them to see, does their mechanics change with that cognitive load? As far as how you could prescribe your rehab, in the article that we had talked about earlier that we tried to do with injury prevention, or that's in review right now, we kind of broke it up into 3 stages. So we had a number of criteria based off of the LESS scoring system, where it was either good or like high number of errors, moderate errors, low errors. And so the goal was to train in the low to moderate error, because if you got into the high error range, then your cognitive task might be too challenging and it is getting in the way of them learning the motor control aspect of what you need them to do. So just like you want to train not at their 1 rep max all the time for strength training, you want to train at 70, 80%. You want to use some sort of scale that you can even develop clinically yourself based off of whatever your initial assessment is going to be, to then say, this is where I need them to be in this moderate difficulty range.
All right. So just to follow up on that question, what are some clinical clues that you're overloading them cognitively during either a test or maybe even during training? What would you see to make you think scale back?
Go ahead.
I would say number one, I caution saying that their mechanics fall apart, because you would expect them to possibly do a little bit worse, but it shouldn't be to the point to where it looked like they never learned the initial task before. I think if an athlete can identify that they didn't move appropriately, or that they didn't complete the goal of the task appropriately with the cognitive load, then that's a good indication that it's an appropriate amount of load. Whereas if they just physically can't complete either the cognitive task or the physical task, then you know that it's going to be too much. But I think that goes back to the clinician having the ability to also count both cognitive errors as well as physical errors. And so it doesn't necessarily, I guess my advice would be, it doesn't necessarily have to be a established criteria of you made this score on this outcome. But that's, I guess, how I would inform my clinical practice.
So Meredith, this is a good question for you. What are your usual goals? Like, how do you set goals? You have to write your initial eval and your progress reports, and check goals. So I think a lot of clinicians for ACL patients are, I don't know, unfortunately using like manual muscle test as a goal, which is not good. But they'll use some hop tests and things. What do you put down as goals? How do you word it? And what do you like? What are your consistent ones you hit on most ACL reconstruction patients?
Are you talking specific to neurocognitive or just in general ACL?
Specific to neurocognitive, things that are going to be a little bit maybe new to some people who are listening or just kind of learning about this stuff.
Clinically, I was a big fan of like the single leg sit to stand test, where you do timed for like 20 seconds, see how many reps that they can do. And so, or items like that, like a speed from sit to box jump, those types of things, because I was able to time an individual at baseline and say, oh, okay, this person got this amount of time, or this person was able to do 30 repetitions of a single leg squat in the given time frame. And then I layered on this serial 7 subtraction, or I layered on a Stroop task at the same time as that. And then they dropped their performance this amount. So then you can use it similar to like a symmetry effect or something like that, where it's like, okay, I want to improve my performance under cognitive load on my single leg squat from 20 to 25, because that should then make the assumption that I'm improving both my cognitive performance and my physical performance simultaneously, rather than just writing the goal to improve my squat performance only.
Great. I love it. Anything to add, Dustin?
No, that was great.
Okay. Well, I just have one more question left. We still have some time, so if people have more questions, please put them in the comment section. But my last question for you is: should we ditch the traditional hop tests in favor of neurocognitive hop tests? I mean, should that be the new standard for what we test and look at in the clinic?
So we published a series of these neurocognitive hops. So they take your 4 basic hop tests that Dr. Noyes published in the 90s. Hop for distance, triple hop for distance, timed hop, and then the 6 meter, the crossover hop. Time hop is for 6 meters. Okay. So we had the 4 classic functional tests. And one of our goals was we did not want to give clinicians another freaking test you have to do, because I feel like it's a lot, and we didn't want to make up some like new neurocognitive agility test, and now you have to do this and your hop test, because that's annoying. So we took the classic hop test, and they're performed almost exactly the same, except we added neurocognitive components. So our first paper was in the International Journal of Sports Physical Therapy, and that was a reliability paper where we showed that they're reliable and healthy participants. And then we did a paper, we compared the performance on these hop tests versus the standard ones. And that was in physical therapy and sport, and we're collecting it now in our ongoing ACL longitudinal trial. So what these tests do, basically we use FitLight sensors, and I will say the FitLights are a fine tool if you have them. They're a little expensive, they're a little hard to program, they're a little older technology. There's some other options you can get. There's a lot of other companies entering this sector, so I would encourage people to explore other options. A-Champs is another company. I just mentioned them because they said they'll put the hop test in their software for free, so it'll be easy for people to use. So I don't get any money from any company, just to be very clear. I get really angry about that because, like, especially physicians, you see some of the conflicts of interest on these physician papers every now and then. Like, okay, so I only have 5 minutes. Okay. Anyway, so I don't really care about company, but this question, I'll finish this real quick, then we'll do this question. So these hop tests, basically, they use FitLights and a light would flash, and they either have a go color, they have a no go color, or it'd be central vision or peripheral vision. So we tried to test different aspects of visual, spatial cognition, and reaction with each test. So all you have to do, you could still do your same noise hop test, get your hop distance like you always did, And now you can get reaction time from the sensors. And what we see is about, depending on the complexity of the cognitive challenge, we see around a 10 to 15% drop in their hop performance just by adding this reactive component. And so if you don't have any technology at all, I would encourage you to just, instead of let your patient do the hop test like normal, make them react to you. So instead of say go on the 2 and then you flash numbers at them and then they jump. Or you can have 2 people and you can do peripheral vision. You can have then you'll just be like, go on the flash. Each person stands there because it's hard to see numbers on the corner of your eye, right? And so I would encourage you just to add this slight modification, what you're already doing. You get the same data you always got, and now you get it with a more reactive component, and it'll at least give you a better idea of how they'll actually perform in a more sport-specific setting. You want to do this last question, Matt?
Yeah, go for it.
I'm sorry,
Take it away, Dustin. I like it.
Okay, but how does fatigue play a role into how you integrate dual tasking or cognitive loading? Do you intentionally try to fatigue patients, and then also add more of this, or what want athletes more fresh to optimize the adaptations? So that's an interesting question. So fatigue, it's very complicated and very hotly debated a little bit on what exactly it is. So you can have physical fatigue and cognitive fatigue. You have central fatigue and peripheral fatigue. It's a lot of fatigues. A lot of fatigues running around. So, sorry. So your question is, would you want to implement cognitive loading when they're in a state of physical fatigue, potentially? So I would normally aiming more at physical fatigue. Okay, thanks for the clarification. So that's an interesting. Let me think about it for a second. Meredith, do you have an intuition?
What I was gonna say is in more of the armed forces literature, when you talk about physical fatigue and then cognitive fatigue with rifle navigation, cognitive fatigue alone without physical fatigue seems to impact their skill or accuracy of performance, but for a short amount of time. Same with physical fatigue alone, because you're naturally going to, if you're going to go fatigue yourself, run a lot, then you're going to shoot this target, you're naturally going to recover from that and your accuracy is going to improve on that. So I am almost hesitant to say one or the other needs to occur, and that some level of both overlap is the easy medium there. But
that's a really interesting question, because especially if you're dealing with physical fatigue and you fatigue someone and then their ability to generate force goes down, so then you could lower the physical load on them, and then you might be that might be an opportunity for cognitive challenges because they can't train at a high load in that instance. I'm not aware of anyone who's examined it that sort of state, but there is some interesting neuroscience literature that some of the neural correlates of fatigue are similar to when they're cognitively loaded. It just takes that much more. You see a shift towards frontal, and some of that is conflated by pain. So what I mean, the shift towards frontal is you get more frontal cortex, more areas we associate with cognitive control, movement, activity as you fatigue. But all the studies are usually confounded by pain, discomfort, and those kinds of things. And then when you have pain, you direct attention to the joint or the muscle, and so that could be secondary. So you don't really know if it's a fatigue effect or an attention modulated effect. Humans are very hard to study because our attention is so malleable. And if we could just control for that, we could answer a lot more questions neurologically. But that's difficult. So that's a cool question. When dealing with a patient who has kinesiophobia, how would you recommend balancing external and internal focus? This is a really cool question. Does this automatically end at 60 minutes, Matt, or do we keep going?
No, it doesn't. It doesn't. But let's make this our last question. We'll wrap up after you.
Okay.
After Brittany's question.
Okay, I didn't want to have it just end at 60 minutes.
No, we're good.
Okay. So this kinesiophobia question is a very good one, and the one issue with kinesiophobia, it seems like there's some interesting data that fear of movement has similar neural constructs as PTSD almost, where people had a traumatic event and now they associate things around that with that traumatic event. And we see some similar neural correlates. We're exploring this in our data now to that, where they basically associate movement with this traumatic event injury. And so actually it seems like internal focus may accentuate that kinesiophobia because they're constantly, you're just reinforcing their attention on the joint. And what we know best about neuroscience is that neurons that fire together will wire together. So if you keep firing this activation pattern where they're attending to the joint and they have fear of movement, and you make their attention on that joint where they have fear, you're just going to be in a bad situation. One of the really cool interventions out of the PTSD literature that we can borrow is like self-contextualized learning. Basically what that means is you try to return on autonomy to the patient, where you give the patient some decision making. So to answer your question, to shift a little bit, external would be better because you take their attention away, but you can actually do more as a clinician. One of our big limiting factors is if someone has kinesiophobia, we're always like, well, we got from the psych and we'll give them the survey and track it. But it's like, what do you do? It's very difficult. There's a lot of really cool motor learning studies that if you give someone autonomy of control, that you can target some of these neural activation patterns that are associated with PTSD and maybe kinesiophobia. And it can be very simple where if someone comes in, it's like, we have to work on your quad strength, and you're a physical therapist, clinician, athletic trainer, you could come up with 100 exercises for quad strength. You give them 10 and then pick 3, and you've given them control. It's very, very powerful. And I think we just leave this off the table because we haven't like connected all the dots in our world yet, but I mean, that's such a small thing you can do. And then you can suddenly, they're in control. And that's where a lot of this locus of control comes from with kinesiophobia, because they had a traumatic event happen to them that they felt like they were out of control for, is where a lot of the psych literature is for that one. So thanks for that question opportunity. Do you want to add anything for that, Meredith, or are we?
No, I think the autonomy perspective is spot on, especially because often, I think the patients pick what they perceive as hard, right? Instead of you telling them like, hey, you need to do this exercise, right? You've already educated them. They already know that. Oftentimes they're going to pick what they're not good at because you gave them the autonomy to do so.
Great.
All right. Well, that was great. Well, thank you guys for making time to answer questions. I think we got some really great questions, and I'm really looking forward to going back through and listening again because there's a ton of information, just like loads. So I think it'll be really useful to come back and play it again. So everyone who's watching right now, this will play back through. So you just come back to the same page and press play, and it'll play back through, and you can skip parts if you want. And I believe that the all of the comments stay as well. And then anyone who missed it, who wants to join it, can do the same thing. They can come in, log in just like they're going to view it, and it just plays as a recorded session. So so I put your Twitter handles down. Do you have any other contact info you want to give? How do people get a hold of you if they want to ask a question or inquire about something?
Twitter is fine. My email is groomsd@ohio.edu. I have a package of things I give clinicians that are a bunch of PowerPoints to get you started with cognitive loading that are pre-timed to a few seconds. And it's like a bank of things to try, so it could speed up you trying some of these out. And I also have a zip file of like our key articles and some like other materials that I'm happy to give out to help. Meredith?
I'm very active on Twitter.
Yeah. Tweet at Meredith if you want to get the question answered. I only check Twitter like every couple of days, so if you want to answer like now for your patient, tweet her. She'll tell you what to do.
That's your best bet. You can email me too. It's just my name at gmail.com.
All right. Well, thanks everyone who tuned in, and thanks Dusty and Meredith. Appreciate your time.
Thank you, Matt.
Thank you, Matt.
Thank you.
All right. Bye, everybody.
See ya.